So thank you very much. I'm Helen, and I'm going to talk about the treatment of relapsed CLL. And then when Renata was putting together these titles, she put in this innocent extra bit about the old chestnut of sequencing, which sounds very innocent. And then obviously thinking with regard to ASH 2023, if there are any new data to help our decisions when we're thinking about how to treat relapsed CLL. So I'm going to try and take you through sort of three main focuses. First of all, what drugs do we have available? So when we're thinking about relapsed CLL, what could we use? And there'll be a lot of overlap here with what Nick's already talked about in terms of what we have available in treatment-naive CLL patients, but with a few little minor sort of things to bear in mind in the relapse setting. And then the old chestnut about, is there a right or wrong order in which to use them? So this question about how should we be sequencing things? And then a few sort of future possibilities. So just highlighting a couple of things from ASH in terms of future possible drugs. And as we go along, if there are relevant up-to-date new data from ASH, then we'll stick those in as well. So first of all, what drugs do we currently have available in the relapsed CLL setting? So just as we've already heard about and won't come as a surprise to you, we're talking about these two main classes of drugs, the BTK inhibitors or the BCL2 inhibitors. And when we're thinking about the BTK inhibitors, as we've heard about already, we've got acalabrutinib, zanubrutinib, or ibrutinib available to us in the relapse setting. I've deliberately put ibrutinib at the bottom of the pile there, because as Nick has already alluded to, and we'll look a little bit more about the toxicity with these three different drugs, many CLL doctors now would tend to choose the other options over ibrutinib because of an improved safety profile. When we're talking about the BCL2 inhibitor we have available, really the only one we've got available in this space at the minute in the UK is venetoclax, when we're talking about in an NHS setting. There will certainly be trials coming with alternative BCL2 inhibitors, and I should think we'll be seeing those in the UK this year. And certainly data was presented in ASH about some alternative BCL2 inhibitors, but what we have currently is venetoclax. And we can either use venetoclax in the relapsed refractory setting, either as monotherapy, in which case it's given continuously, or venetoclax given it in combination with rituximab as a fixed duration combination. And just to mention that the BTKIs are always in relapse, we're giving them as a continuous monotherapy. Now I have just included PI3 kinase inhibitors there. They're deliberately smaller and in paler font because we're always going to choose the BTK inhibitors or the BCL2 inhibitors over the PI3 kinase inhibitors. When we're talking about PI3 kinase inhibitors, specifically, we're really talking about idelalisib, which we can give in the relapse setting in combination with rituximab. And I think when you've run out of options and you're casting around for something else, it is an option and it can work in patients who've already been exposed to these two other classes of drugs. But I'm only going to sort of show you very minor data about PI3 kinase inhibitors as we go along, and you'll see that the PI3 kinase inhibitor always does worse than the other targeted agent on the slide. So we're never going to choose it as our first option. And then at the bottom, chemoimmunotherapy with a big red cross on it. So Nick has already told you, we've seen the data from the CLL13 Gaia German group study in frontline CLL, that chemoimmunotherapy now really does seem to be dead in the water in treatment-naive CLL, and that's been the case in relapsed refractory setting for a number of years, because when chemoimmunotherapy is compared with these targeted agents in the relapse setting, chemoimmunotherapy always comes out worse. So chemoimmunotherapy has been a goner in relapsed CLL for a number of years, and I wouldn't recommend using it in any setting really in relapsed CLL. So we'll start with the BTK inhibitors first, and obviously you've heard a lot about the BTK inhibitors already from Nick in the frontline setting, but here we're focusing particularly on the data in the relapsed refractory setting. We'll start with ibrutinib, just because that's obviously where it all began, and so it's relevant to kind of point out the data that we have. And you can see this is quite an old study, and this was a 6-year follow-up, and it was published in 2019, and this was the Resonate study. So this is where it kind of all began for ibrutinib in relapsed CLL, compared with ofatumumab, a monoclonal anti-CD20 antibody that we don't use. And obviously we would never really use it as a single agent anyway, so not a great comparator arm. But what we're really interested in here is seeing that ibrutinib in these quite heavily pre-treated patients who had a lot of chemoimmunotherapy lines before, because this was prior to all these novel targeted agents, with a median progression-free survival of 44 months. And that was reflected in the right-hand panel here as well, in the genomic high-risk population patients as well. And one of the important things, and we've already sort of alluded to this in the treatment naive data, but in the relapse setting in this RESONATE study, really importantly, we saw that the IGHV status didn't affect the progression-free survival. So as you've heard earlier this evening and you'll have heard last week, we know that the IGHV status in CLL is important in terms of prognosticating response to treatments and outcome, and that the unmutated IGHV patients tend to have poorer outcomes. But in this RESONATE relapsed refractory study, the IGHV status did not affect the progression-free survival. And we'll see that as we go on in other BTKI studies. So moving straight on to acalabrutinib, and we're talking about two main studies in acalabrutinib in the relapsed refractory setting. So first, the ASCEND study. And here acalabrutinib was compared with physician's choice of either chemoimmunotherapy with bendamustine rituximab, or, and this is the first time it appears on the slide, and I told you it would always do worse, idelalisib and rituximab was the other physician's choice option here. But acalabrutinib clearly beating both of those two options with a 62% progression-free survival at 42 months. Now, when we look in this ASCEND study, looking at these two sort of high-risk features, I've already shown you with ibrutinib in the RESONATE study about the IGHV status. If we look at the bottom panel here first, just concentrating on the red and the blue lines at the top, where we're looking at the comparison of mutated IGHV or unmutated IGHV status treated with acalabrutinib, and you can see those red and blue curves are overlapping. So the IGHV status is not affecting the progression-free survival with acalabrutinib, just as it wasn't affecting the outcomes with ibrutinib in the long-term follow-up from the RESONATE study. And then in the top panel, you can see that the p53 is also not affecting outcome with acalabrutinib in this ASCEND study. So whether patients did or didn't have a p53 aberration. Then moving on to another acalabrutinib study in the relapsed refractory study. So we've already heard from Nick about the 6-year follow-up that was presented at ASH of the Elevate-TN, so the Elevate treatment naive study. This is the Elevate-RR, so the Elevate relapsed refractory study. And this is a head-to-head study of acalabrutinib and ibrutinib. And the most important jump out feature here being this hazard ratio of 1. This study demonstrated that acalabrutinib was non-inferior to ibrutinib and they were of equivalent efficacy. Just to note that in this patient population, there was quite a high rate of sort of high risk genomic changes, so particularly deletion 11q and p53 aberrations. And when the patients were separated out according to their del11q or del17p status, again, acalabrutinib and ibrutinib were of equivalent efficacy. So we're comparing the two dotted lines at the top first, red for acalabrutinib and blue for ibrutinib, looking at the del11q status, and you can see that the curves overlap. And then the solid red and blue lines, red for acalabrutinib, blue for ibrutinib, looking at the del17p status, and again, the curves overlap. So equivalent efficacy when we divided the patients out according to these high-risk features. But this is where acalabrutinib sort of won in terms of this safety events. So this direct comparison of acalabrutinib with ibrutinib. And so you can see we've kind of got the any grade events in the first two columns, and then the third and fourth column are grade 3 events and above. First of all, to point out this feature about headache. Many of you will know this already, but we predict about 1/3 of patients treated with acalabrutinib will develop a headache. You can see that it's about 1/3 of patients of any grade get this headache. If you look in the grade 3 or above events on the right-hand side, it's very, very low level, 1.5% of patients getting a grade 3 headache. So low sort of severity, but definitely 1/3 of patients getting a headache, which apparently tends to be very caffeine responsive and usually is short term. So just in the first few months of treatment and then seems to spontaneously improve. But when we're thinking about the specific sort of BTKI associated side effects that we've become very used to and cautious about with ibrutinib, so I'm thinking about hypertension, atrial fibrillation and bleeding events, it does seem in this head-to-head study that acalabrutinib is doing better in all 3 of those compared to ibrutinib, so both hypertension, AF and bleeding events. I'm going to move on now to zanubrutinib, so in the relapsed refractory setting, and this data was updated at ASH 2023. So this is the Alpine study. And like the Elevate-RR study that we've just seen, which was a head-to-head direct comparison of acalabrutinib with ibrutinib in the relapsed refractory setting. The Alpine study is a direct head-to-head comparison of ibrutinib with zanubrutinib in the relapsed refractory setting. And this data was first presented at ASH 2022, and then a further year of follow-up updated in ASH just before Christmas. So these are relapsed refractory patients with at least one prior line of treatment, but they could not have been exposed to a prior BTK inhibitor. And then a one-to-one randomization between zanubrutinib and ibrutinib, continuous treatment until disease progression or toxicity. Nothing too surprising in terms of the patient characteristics. You can see they were treating patients up into their late 80s and even a 90-year-old patient in the zanubrutinib arm. And just a slightly higher sort of incidence of P53 aberrations that we might expect than we might usually expect in treatment-naive patients, but these are obviously relapsed patients who may have acquired some mutations. And the key thing to look at here, and this was talked about a lot at ASH 2022, and now this has been sustained with the extra year of follow-up at ASH 2023, is that there seems to be a PFS benefit of zanubrutinib over ibrutinib in this relapse setting. So whereas we saw that acalabrutinib and ibrutinib appeared completely equivalent, there does seem to be a bit of benefit of zanubrutinib over ibrutinib. And in particular, this is played out in these P53 aberrant patients, which I think is really interesting. I've included this slide about complete responses, really not to make any particular point whatsoever about the comparison of ibrutinib or zanubrutinib, but really just as a point specifically about BTK inhibitors. So as just one little kind of nugget of information, which you may know already or might come as news to you, as just like a little nugget of information that I always have in my head when I'm thinking about the comparison of BTK inhibitors with venetoclax. I kind of think of a BTK inhibitor as being a bit of a snail and venetoclax as being a hare. If we look at this over time, so we're starting on the left from 6 months all the way through to 48 months on the right-hand side, and we're comparing ibrutinib in blue bars with zanubrutinib in green bars, but the majority of these bars are all pale color. So these are all just representing partial remissions. The number of complete remissions here is actually very low. Even on zanubrutinib at 48 months, the very far right-hand green bar, we're only seeing a 10% CR rate. Now, if you think back to some of the data that Nick has already shown us, where patients are receiving venetoclax-based treatment, we were seeing much higher rates of complete remission and MRD negativity. So it's just quite a different sort of treatment response you get with a continuous BTK inhibitor compared to a venetoclax-based treatment, where we see good disease control with good overall response rates, but not necessarily achieving very deep or complete responses. So that's the reason I included this slide, really is a comparison between BTK inhibitors and venetoclax, rather than to show you anything in particular here about the comparison of ibrutinib and zanubrutinib. So then if we look at the adverse events of special interest in this direct zanubrutinib versus ibrutinib comparison, so you'll remember that when we looked at the Elevate-RR study and we picked out hypertension, bleeding, and AF, acalabrutinib seemed to have lower rates of those three major features compared to ibrutinib. Bleeding isn't highlighted here, but if you compare the rates of any grade bleeding in the left, first column on the left with zanubrutinib compared to the third column, any grade bleeding with ibrutinib, you'll see they're basically the same. Similarly, with hypertension, the rates of hypertension between zanubrutinib and ibrutinib, basically the same. And again, with neutropenia, basically the same rates. So we're not actually seeing any improvement in terms of toxicity profile, particularly in bleeding, hypertension, when we're comparing zanubrutinib and ibrutinib. The difference, however, does seem to be in terms of atrial fibrillation, flutter, and other cardiac arrhythmias or significant cardiac events in zanubrutinib compared to ibrutinib. So I think that's just a bit of a kind of key message that certainly sticks in my head when I'm thinking about ibrutinib, acalabrutinib, and zanubrutinib. I do think that acalabrutinib seems to be more tolerable against a wider range of toxicities, including things like arthralgia, bleeding, hypertension, rash, fatigue, so on. But zanubrutinib seems to be quite similar to ibrutinib, but picks out in particular the arrhythmias and the AF as being possibly fewer events compared to ibrutinib. And this just shows us in the Alpine study, the number of events of AF over time being fewer in the zanubrutinib arm in the sort of yellowy green color compared to the blue ibrutinib arm. So I'm going to move on to the BCL2 inhibitors. So in the relapsed refractory setting, we've said we can either give venetoclax as a continuous monotherapy or venetoclax and rituximab as 24 months fixed duration. So different to when we use it in the treatment-naive CLL setting, where we give it for 12 months with obinutuzumab. In the relapse setting, we're giving it with rituximab for 2 years. And we can have 6 cycles of rituximab and 2 years in total of venetoclax. So this is from sort of the very early data of venetoclax in the early phase studies published by Stefan Stilgenbauer back in about 2016, where we saw the benefit of venetoclax in really high risk patients, so relapsed refractory patients with p53 aberrations. So you can see here the incidence of p53 mutations, about 3/4 of patients. Because this was quite a few years ago now, only around 11% of patients have been exposed to a prior B-cell receptor inhibitor, such as ibrutin or idelalisib. Many of these patients had had other chemoimmunotherapy-based regimens previously. And this is just giving an idea of the overall response rates in these very high risk p53 aberrant patients, that we were seeing these high overall response rates. Just note there, just bearing in mind what I just said about the low CR rates with BTKIs, even in this really high risk group, we're seeing a 20% CR rate with a venetoclax monotherapy. And this just shows you some of the progression-free survival and overall survival endpoints in this venetoclax monotherapy study. But we're more likely nowadays in the relapsed refractory setting to use venetoclax and rituximab in combination over this 24-month fixed duration treatment. So this is based on the Morano study, where we can use venetoclax and rituximab in fixed duration for 24 months. We have 6 cycles of rituximab and 24 months of continuous venetoclax after the initial 5-week ramp up. And in the Morano study, this was randomized to compare with 6 cycles of bendamustine rituximab chemoimmunotherapy. This 7-year outcomes were updated at EHA last year by Arn and Cater. This is a 7-year progression-free survival with a median progression-free survival of 54 months. So sort of 4.5 years in the venetoclax rituximab arm, clearly doing better than the chemoimmunotherapy arm here. When we divide these out into the sort of risk groups that we know about, so the IGHV status and the p53 status, bearing in mind what we've seen with the BTK inhibitors, where the continuous BTK inhibitors don't seem to have such a differential when we apply IGHV status or p53 aberration. You can see here that with venetoclax rituximab, IGHV and p53 disruption do have an impact on outcomes. Excuse me. So we've got here a bit of a summary of the drugs we have available currently and the sort of key data, the key studies and publications that support those drugs. So coming on to the second bit, is there a right or wrong order in which to use them? How do we decide about sequencing? Does it matter which order we use them in? We've already talked about this a bit in the discussion. You know, when we're talking to our patient and thinking about what the right treatment option is, we're going to be thinking about toxicities. Are there comorbidities in the patient that might influence this? Somebody asked the question about a patient who's had a recent MI, and are we going to want to give them a BTK inhibitor, or we're going to avoid that because they're on antiplatelet therapy and they've just had a stent and so on. So there's going to be things related to the patient, things related to the disease in terms of IGHV status and other high-risk features. And then obviously taking into account the patient preference, whether they might want to think about fixed duration or continuous treatment. So all the kind of things we've already mentioned in the treatment naive setting. But in the relapsed refractory setting, probably the most important first question is, what has the patient already had? And when we're thinking, sitting here right now, the potential options that patients might be having right now in the sort of treatment naive setting obviously include I+V. So in the future, we might be looking at patients who've had I+V as their first line treatment. They might have had a continuous BTK inhibitor as their frontline treatment. They might have had venetoclax and obinutuzumab. It's possible we're still going to be encountering a handful of patients who have had chemoimmunotherapy as their frontline treatment and are now encountering their first relapse. So what has the patient already had? And then definitely key questions. Why did it stop? So did that treatment they've had before stop because they got to the end of their planned fixed duration treatment? Or did it stop because of progressive disease on the treatment? Or did it stop because of toxicities and side effects and the patient couldn't tolerate the treatment? So I think those are the kind of two really key features. We can then start to think about the data we have to support us in using one of these targeted agents, in what order we use them in and when we can use them one after another. So first of all, if we think about using venetoclax after a BTK inhibitor, we have prospective data to support the use of venetoclax after a BTK inhibitor. So overall, when we're thinking about the data we have to think about sequencing, we don't have these large randomized phase 3 studies. So we don't have as much data to make the treatment decision as we have to sort of support the initial use of venetoclax or BTK inhibitors. We have a combination of some retrospective and some prospective data to support our decisions. So in this study, published initially in the Lancet Oncology and then subsequently updated at IWCLL last year, a study of 127 patients, and this was a non-randomized phase 2 open label study looking at patients who'd had a previous B-cell receptor inhibitor. The majority of them had had previous ibrutinib, but some had had idelalisib, and they were now relapsed and needing another treatment. And essentially, the updated outcomes presented at IWCLL last year demonstrated that venetoclax monotherapy was effective in all of these patients, regardless of their frontline B-cell receptor inhibitor. So we saw some prospective data there for the use of venetoclax in that setting. We have some retrospective real-world data from the UK CLL forum, looking at the outcomes when patients go on to venetoclax when they've progressed on a previous B-cell receptor inhibitor. So looking here at real-world data published by Toby Eyre, where patients were treated with venetoclax after a prior B-cell receptor inhibitor. 2/3 of them, as you can see here, the prior B-cell receptor inhibitor was ibrutinib or another BTKI. About a quarter had had idelalisib, and 10% had both a bruton tyrosine kinase inhibitor and idelalisib. In terms of their outcomes, if they progressed on their previous B-cell receptor inhibitor, so the dotted line, then they clearly had worse outcome in terms of progression-free survival compared to the solid line for patients who'd not progressed on their B-cell receptor inhibitor. We have some retrospective data for the use of BTKI after venetoclax. So this was published by Anthony Mato et al. A few years ago, a large international retrospective study, 326 patients. These patients had all been previously treated with venetoclax, and the absolute vast majority of them, so 96%, had venetoclax in a relapsed refractory setting. So they'd already had other prior lines before they'd even got to venetoclax. And the median number of prior lines of treatment was 3. So these patients had a lot of treatment before they'd even got to venetoclax. 40% of them had never had a BTKI before. And the most common next line of treatment in this study was a BTKI. Now, there's a couple of different things to pick out here. The first thing in this retrospective study is to just look, first of all, in the panels A and C. So if we look in the top panel A, we're looking here at these patients who've had venetoclax, now need retreatment, and they're getting a BTKI, and they've never had a BTKI before. And we can compare that with panel C in patients who've had venetoclax before, now need another treatment, and are getting a PI3 kinase inhibitor like idelalisib, and they've never had one before. And you can see here clearly that the BTK inhibitor is doing better than the PI3 kinase inhibitor. So another bit of data where the PI3 kinase inhibitor is always doing worse than the other thing on the slide. And so in these post-venetoclax patients, we're always going to be choosing the BTK inhibitor over the PI3 kinase inhibitor. But then important to point out, in patients who had had BTK inhibitors before. So we said a proportion of these patients, because they've been through several lines of treatment before they first got to venetoclax, and some of them had had a BTK inhibitor before they'd got to venetoclax, and now they need retreatment. So when these patients were retreated and went on to a BTK inhibitor again, the patients who had stopped their BTK inhibitor in the past because of toxicity, so the top line, which is sort of bluey color, clearly did better than those who had to stop their BTK inhibitor in the past because of CLL progression. Can we use the same drug again? So when we're thinking about our targeted agents, if somebody's done well on one before, can we get it out and use it again? We have some prospective data for this. So specifically from the Morano study, they're small to moderate numbers of patients here. So this is the Morano study that you'll remember was the venetoclax and rituximab combination study. 67 patients went on to have progressive disease after venetoclax and rituximab. 32 of those were retreated with venetoclax-based treatment with an overall response rate of 72%. So a pretty decent overall response rate in retreatment in patients who've progressed having been treated with venetoclax before. This study also, it's a very small number of patients, but does also give us some information about BTK inhibitors prospectively after venetoclax, because a prior BTK inhibitor exposure was excluded in the Morano study. So these patients who went on to have treatment with a BTK inhibitor after progressive disease with venetoclax rituximab had not had prior exposure to a BTK inhibitor and had a 100% response rate when they were subsequently treated with a BTK inhibitor. A little bit from Captivate. This is obviously looking at the data from ASH 2023. And Nick has presented some of this already, because obviously this was a treatment-naive study. And what Paolo Ghia presented at ASH 2023 was specifically looking at the 202 patients who'd been treated in the fixed duration of this study. So the Captivate study had a fixed duration cohort and an MRD-driven cohort. And he presented the data at ASH 2023 for 202 patients who had received just 15 cycles of ibrutinib and venetoclax, so the same as what we currently have access to. These were young, fit patients. And of the 53 patients who progressed, you won't be surprised to see that they were enriched for these sort of high-risk genomic features, the P53 aberrations, del11q, unmutated IGHV status, compared to the patients who didn't progress. What was really interesting was that they went on specifically to look to see whether of these patients who had progressed, did they have recognized mutations in BTK or PLC gamma 2, which are recognized mutations known to be associated with resistance to ibrutinib, or mutations in BCL2, which is known to be associated with resistance to venetoclax. And in the 40 patients out of the 52 who progressed, the 40 patients they evaluated, none of them had BTK or PLC gamma 2 mutations identified. There was a low-level subclonal mutation in BCL2 identified in one of the patients of an unknown significance. And when these patients went on to be retreated with ibrutinib-based treatment, then you can see that they had very impressive overall response rates again. So we have this overall response rate, just a very low complete remission rate, as we know occurs with the continuous BTKI. On the left with single-agent ibrutinib. And then on the right, some of the patients were retreated with I+V in combination, very small numbers, only 6 patients, but again, a very good overall response rate with a CR rate of about a third of the patients. So the authors concluded when they presented this data at ASH that this first-line fixed duration treatment of I+V may mitigate against the development of the resistance mechanisms which we know can develop when patients are treated with continuous single-agent targeted therapies and can be associated with resistance if we were to consider retreatment again in the future. And that when we use ibrutinib-based retreatment in these patients, we're seeing promising results when patients need treatment again. So that's prospective data about using ibrutinib-based retreatment after I+V. Just a quick little bit of data, and Nick has already sort of alluded to this, that can you change from one BTKI to another? Well, again, this was presented at ASH 2023 about swapping for toxicity. This is a phase 2 study, and this wasn't just CLL. There were other indolent lymphoma patients here, LPL, marginal zone, mantle cell. But essentially, when patients had had to stop either ibrutinib or acalabrutinib because of toxicity, and then they were retreated with zanubrutinib, you can see that in the majority of patients, coloured in blue, then the toxicity that had been a problem on the ibrutinib or acalabrutinib did not recur. In a small number of patients, the toxicity did recur, but it was either at a lower grade, the green bits, or at the same grade, the orange bits that they'd experienced before, and never at a higher grade because there's no red bits on the chart. So, possibly unhelpfully, I'm going to conclude that there's no clear right or wrong order. And I think this really comes down to what George was saying before in terms of when we're first talking about treatments with a patient, we're kind of strategizing and thinking about what are we trying to achieve with this particular patient? Where are we going? What duration of response are we trying to achieve at what stage in their treatment? But what we do know, based on a collection of both prospective and retrospective data, is that we can effectively use a BTK inhibitor after venetoclax or vice versa. That we can use venetoclax to retreat in patients who've been previously exposed to venetoclax fixed duration, and that there is evidence from the Captivate data that we can use ibrutinib-based treatment after I+V, bearing in mind that in all of these studies, we're talking about tens of patients, maybe 100 and so patients. We're not talking about large randomized studies. And we know that using an alternative BTKI is an effective and useful strategy if we've had to stop another BTKI because of toxicity. Now, I'm just going to say a little bit about pirtobrutinib because we're in a relapsed CLL talk. Normally, when people show me a picture like this, I completely gloss over and stop concentrating. So I'm going to highlight the important bits in red. If you're a covalent BTKI, then you look like this. You're a yellow and blue blob. So when we're talking about the covalent BTK inhibitors, we're talking about ibrutinib, acalabrutinib, zanubrutinib. And if you want to bind and do your job, then you need to be able to bind to this bit here, C481, and it needs to not be mutated. If you're a non-covalent BTK inhibitor, such as pirtobrutinib, then you look completely different. It doesn't matter whether this bit is mutated because you don't need to bind to it to do your job. So this is about the fact that if you've got a C481S mutation in BTK, which is one of the mutations we know can be acquired, and George has just told us that it can also occur spontaneously in previously untreated patients, which I did not know. But if you've got a mutation C481S, then that is going to have conferred resistance against these covalent BTK inhibitors, but it is not going to have a potential effect on your response to the non-covalent BTK inhibitors because it's not an important bit of the binding site for them to do their job. So over the last 3 ASHs, we've seen data in the Bruin study, looking at pirtobrutinib in a number of lymphomas, but looking particularly useful in CLL. And there was some updated data presented at this ASH. So this is just to give you an idea of what we know already from the early phase Bruin study. In the CLL patients, over 200 patients treated, patients 100% who've had prior BTK inhibitors, a fair number, 40% have had venetoclax, even a bit of CAR-T and allogeneic stem cell transplant chucked in there. But you can see that 40% of the patients have mutations in BTK, which we know confer resistance to the covalent BTK inhibitors. The data that was updated at this ASH was looking at how patients treated with pirtobrutinib did if they'd been exposed to a prior so they've all been exposed to a prior covalent BTK inhibitor, but it's whether they've been exposed to venetoclax or another BCL2 inhibitor in the past. We've got the BCL2 inhibitor naive patients on the left, the BCL2 inhibitor exposed patients on the right. And you can see that the patients who are naive to BCL2 inhibitors are actually responding better to pirtobrutinib than the double refractory patients who've previously been exposed to both a covalent BTKI and a BCL2 inhibitor. And I've just brought this up, and George kind of mentioned this a little bit just before we started this talk. And I think this probably will become more important as we learn more about this. This was another abstract presented at ASH 2023, specifically related to pirtobrutinib. And this was talking about the genomic evolution that had been detected in patients who progressed on pirtobrutinib. And patients with progressive disease on pirtobrutinib, we've seen that the C481S mutation, that's a problem for covalent BTK inhibitors, isn't an issue for pirtobrutinib, and they weren't seeing new acquired mutations in C481S frequently at all in patients progressing on pirtobrutinib. But they were seeing different mutations at different sites, L528W and T474I. And we need to think about this, I guess, the question that somebody asked earlier in terms of should we be looking for BTK mutations in all patients. This might become something we need to think about in the future, particularly as we get these non-covalent BTK inhibitors available in the future, hopefully, and how we sequence these. If we give one drug, are we potentially making somebody resistant or leaving the door open to use other BTK inhibitors in the future? So I think that is going to have an impact on sequencing in the future. This is very brief. I can see Renata hovering there, and we're coming to the end. So I've just got a couple of slides really for future possibilities. And this is opening the door for Piers Patton, who's going to talk about trials next week. In terms of future possibilities, Tanya Siddiqui presented some data on lysocell, CAR-T cells and CLL. So these are relapsed refractory patients who've had multiple prior lines of therapy, high-risk patients. You can see that they had a full study population in the left-hand column and 100% patients with BTK progression or venetoclax failure in the right-hand. So these double refractory subset of patients, 70 patients in the right-hand column. I just picked out here this sort of 12-month follow-up that in the full study population at 12 months, we've got a sort of 55% progression-free survival. We've basically reached the median progression-free survival at 12 months in the patients who've been double refractory to both BTK inhibitors and venetoclax previously. And this is just a highlight. If we look at the full study population on the left, so 88 patients, and then we look at my little red box on the bottom, 17 of them achieved a complete response. So it's quite low numbers of patients achieving a complete response. If they achieve a complete response in this light blue, they do really well. If they don't, these partial responders, they're clearly doing less well. And then if we look at this next slide, the non-responders in the reddy brownie colour at the bottom are doing absolutely dreadfully. So you can see this sort of 50% progression-free survival within 6 months. So basically, if you respond to CAR T cells, you're doing very well, but it is just a small group of patients who are achieving this complete response. One slide on new drugs, definitely opening the door for Piers Patten for next week. BTK degraders will be really interesting to see where these go. There are a couple of different products available already in early phase clinical trials from BeiGene and Nurix, and these are available in the UK already. 43 CLL patients treated so far, many of them double refractory to the BTK inhibitors and the BCL2 inhibitors, and thus far seeing a sort of mixture of partial response and stable disease. So in conclusion, we've just done a quick run through the data for BTK inhibitors in relapsed refractory CLL, just showing in the Elevate-RR study the equivalent efficacy of acalabrutinib and ibrutinib. That in the Alpine studies, ibrutinib looks at least equivalent, if not possibly better than ibrutinib. In terms of toxicity, in my head, it's very simple. I'm keeping it very simple in my head. Acalabrutinib to me looks just a little bit across the board better than zanubrutinib, which looks better than ibrutinib just in terms of those kind of significant cardiac toxicities and arrhythmias. And we don't seem to see the adverse impact of P53 or IGHV status affecting outcome when we're thinking about continuous BTKIs. Whereas with venetoclax and rituximab in combination relapsed refractory, IGHV and P53 do affect outcome. Sequencing, we've seen that we've got some both retrospective and prospective data to kind of show us that we can use these novel agents or targeted agents one after the other, and we're still seeing responses. But I think we need to think about the mutation profiles that are developing after progression on the different BTK inhibitors and whether this is going to affect what we want to do in the future. And then these future possibilities, more on that in the trials section next week. Thank you very much.
Thank you, Helen. That was amazing. Huge amount of data covered in only 40 minutes and loads of new information. So thank you for that. I think one sort of important point is that whenever we're deciding on a first line treatment, I think it's already we kind of making decision on a second line treatment. And I think that's why we put those two talks together, because I think that's quite important, and just kind of think so the patient has got option for absolutely everything. So there are obviously drugs like obinutuzumab we can't use in a second line, but essentially everything else you presented, we can use in a second line. So question to you, ibrutinib, obviously we've been using ibrutinib, I think, I believe this year is 10-year anniversary, or was it last year? 10-year anniversary. It's been 10 years since we've been using it. We've got huge amount of data. Yes, we've got head-to-head, 2 studies head-to-head. But are you prescribing any ibrutinib currently to any of your patients? And I mean, is it better for the devil you know? Because obviously we've got 10 years of data. We making that leap assumption that with newer agents, are they really better? Well, we've seen the efficacy, we've seen side effects. What's your thoughts about ibrutinib?
I don't really prescribe ibrutinib anymore in CLL. Obviously, we've got the I+V, that's a separate question, isn't it? That's whether you want to use the I+V in combination. But if I'm thinking about continuous BTK inhibitor monotherapy, then no, I wouldn't choose ibrutinib at all. And I think they're the best of the devil, you know. I think we've got lots of experience now with acalabrutinib, and we're seeing quite long-term sort of outcomes now, the published data, you know, we've got years of follow-up now with acalabrutinib. I wouldn't be prescribing ibrutinib really because that toxicity profile. I think we've got better agents that we can use now.
Thank you. George, the question about allo transplant, when would you consider? I mean, obviously, thank you, anonymous attender. The bendamustine, I would say, as Helen said, there is big cross. I think let's get it clear today. There is no place for any chemotherapy, including bendamustine rituximab or chlorambucil obinutuzumab. Even if you think it's a mild, gentle chemo, there is no place for any chemoimmunotherapy in a second line, and there will be no place, especially after FLAIR data, in a front line either. So let's just get this chestnut thing out of the way. So there is no place of chemo. Now, allo.
Wow, Renato, we just told off
Oh,
one of the delegates. I'm going to defend them because I think they were asking in the future. Because, I sit there
Oh, in
thinking,
the future. Yes, thank you for
so-
that.
and then, I sit there thinking, right, I'm 55. So 5 years from now, when I retire and I hand over this big bag of problems to my colleagues who I've just been putting people on BTK, I'm giving this drug, they're all very well. But there is a risk they're going to burn through these treatments. And I remember a few years ago saying, gosh, I can't imagine allografting CLL. And then lo and behold, we did 2 last year, and both of them had gone through everything. They'd done their chemos, they'd done BTK, venetoclax, actually back to BTK, non-covalent BTK. They hadn't done bispecifics. We'd been lining them up for CAR T, didn't get time, and went to allogeneic transplant. One of those has now gone through that and is back on nemtabrutinib in the 003 trial. That drug I don't think featured, may have missed it. But so there are loads of things happening. They're very exciting, but I don't know. I look at those BTK degraders and I'm slightly underwhelmed by the response. And I'm getting myself a little bit anxious that all of a sudden our current SHOs, junior registrars, might be rediscovering chemotherapy, and they'll be saying they've got these great new drugs. The brilliant advantage is they're not targeted, so they get all these extra mutations because they're not just homing in on one pathway. I say that cynically, of course I do, because the targeted therapy revolution has been amazing. But allograft, it's going to be that. I think the tone of that question was, come on, guys, if you're 35 and you present and you give them Veno and you put them in a remission, is there not some logic for trying to allograft them? And of course, there are still firm believers around the world. Yet we as CLL doctors, we just can't bear making our patients ill, can we? we
I
really
have two
struggle with
patients
that.
on the go at the minute. I have 2 patients on the go at the minute, one in their 30s, one in their 50s, and both of them I'm having that allogeneic transplant debate. And I think it's impossible not to think about it in a 30-something-year-old. And then the 50,
Nicholas is coming in. He's a keen young consultant.
and a 50-year-old, similarly, I think it's really tricky. So I am talking to both of them about allo, but I think, like you say, George, we don't like making our patients really ill with allo. I can't quite bear to hand them over to my allo team, much as I love them. And similarly, you've mentioned your patient from last year now on nemtabrutinib. I mean, our experience has been they all end up relapsing within a couple of years, and then you pull your new thing out the bag anyway. And then I worry, will we potentially made them ineligible for other things because they've had a prior allogeneic transplant trial-wise, or what if they die of the toxicity along the way? But I definitely think it's something we that's potentially is still on the table, because
Yeah, I think allo became even more
forever.
attractive because CAR T was disappointing, unless you've got any fantastic way to choose that 30% of patients who do relapse. And I think what we've learned from targeted therapies, that if somebody is not responding to those 2 targeted therapies, they do really, really badly. So I think in a way, we've seen kind of renaissance of allo for those particularly bad patients. Nick, sorry.
Yeah, I want to
Sorry, Helen.
echo George's a word about allo. So I have referred also 2 patients in the last 6 months who've gone through all drugs on the Heaven, and they've got no further options. So it is becoming, after many years of having both venetoclax and ibrutinib available, a reality for many of our patients, unfortunately. I just a couple of experiences and a couple of messages about allogeneic. We're keen allografters in Nottingham, as you probably all know, so I'm quite big defenders of it. But I've managed to 2 experiences. I have now currently an allograft patient who was allografted 10 years ago and relapsed 10 years later, being TP53 aberrant and completely naive to all novel agents. So if you think about what has the allograft given this patient, P53 allograft 10 years ago, it's actually bought him time. So he's now have a relapse CLL, has no GVHD, and has all the treatments available to him. And another patient who was previously refractory to everything, and after allograft, he's been proven to be susceptible to BTK inhibitors again, even though he's progressed on them before. And there's some some change in clonal dynamics, and some people who there might have the emergence of clones that might still be susceptible to BTKs or to BCL2 inhibitors later on after allograft. So it comes to the point I want to make about allografts is basically another line of therapy, and that should be considered as that. It buys people time, and when people don't have any other options, then you might give them a few years of disease-free in order to be able to access newer drugs. And this field is moving. So 5 years time, 3 years time, 4 years time, they might have access to other new drugs, and they just might keep going. And that's has been my experience with allograft. And also when you try to sell allograft to a CLL patient, again, it's really hard to send the patient with a PS0 to an allograft, and it's important that they know what they're going into. And the figure is about a third. So a third of the patients will go into allograft and will be disease-free, GVHD-free survival, probably for a long term. So something to keep in mind when you're thinking about sending your patient to an allograft.
Yeah, Lilia and John, I would like to ask you a question about allograft. Is that, Helen? Sorry, I interrupted you. Did you want to add anything?
The only thing I was going to say was when we're sitting at the start, say you've got a 30-year-old patient, or somebody where an allo might be on the table at some point, and you're at that very starting point that George was talking about, where we're mapping things out. Does that affect how you start right at the beginning? Because something in my head tells me if we're going to do an allo, you want the patient to be in remission at the time you do your allo. And if you give them a continuous BTKI, you don't get really deep remissions. So while we might typically go to venetoclax and obinutuzumab in our front line, if we're thinking this patient ultimately might be an allogeneic candidate, should we be holding off that venetoclax-based therapy for a later line of treatment so that they're in their best remission at the time they come to their allo? Or do we work on the basis that, fingers crossed, hopefully we'll be able to use a venetoclax retreatment at a later date and get them back into a deep remission then? These are the kind of things that worry me.
Yeah, George or Nick, have you got, that's an interesting point. Anything to comment on that?
I like that philosophical point, and it is difficult. So first observation about BTK, this discussion that with BTKs, there is actually a minority who are doing extremely well. And these are the patients we've stopped. So I just had one the other week. She's complex third line ibrutinib. She's one of my few patients on ibrutinib for 7 years. Then she had a run of ventricular tachycardias, had a collapse. I've stopped it. Very stressed about everything. So I've broken my rules and done MRD on her peripheral blood. Can't see any CLL at all. CT scan, no lymph nodes. So of course, I'm leaving her off all drugs now. And we all have these patients in our clinics who've gone into remissions, and I've got a few that are now 4 years out from the last time I had a BTK. So although I like your premise, Helen, that keep venetoclax to clean out the marrow, when you're planning so many unknown variables, then you throw in the variable of time. 10 years from now, it might all be very different.
Yeah.
It gets very difficult. And I cut
think
off John as
I think
well.
it just makes sense about using a continuous BTKI just before an allo. It doesn't quite feel like the deep response you want in something if you're building up to an allo. That's the thing that worries me.
I hear that. I hear that.
And maybe this is when you would switch it to ibrutinib rather than just to get those T cells in a better shape, like the using ibrutinib before CAR-T. Just the thought. Lilia and John, were you ever, I'm sorry, I feel really awkward to ask you that question, because this is something, obviously, I know you both been through the mill of all therapies. Was the allo ever considered, and what's your attitude to allo?
Maybe if I go first, because I actually had a stem cell transplant back in 1997, but it was an autologous one. It took a big chunk out of my life. On the plus side, it then gave me a period, my longest period of remission. So that was good. The allo one, it's never really been an option because we've always considered other treatments, and having had the autologous one, it didn't feature on my radar, to the best of my patient perspective knowledge.
Yeah, when I had my first line treatment, which was like John some time ago, that was back in 2010. At that point, I was told that if and when I relapsed, it might be an option, but I've never had any more detailed discussion than that. Could I turn the discussion around a little bit and go back to what George's? I know you were doing it slightly tongue in cheek, that young haematologists might eventually come back to chemo as a chemoimmunotherapy as the great new treatment. I'm slightly puzzled why FCR is being disregarded quite so quickly for exactly the reasons you're discussing. I've had FCR and I've had I+V, and one of my big concerns about taking I+V was that I put all my eggs in one basket. What was I going to have next?
Leland, can I answer a little bit back? I know we're pushed for time, because I often throw out really ridiculous things that I shouldn't say. So I guess one of the worries about chemotherapy, and it is a fair statement, that alkylators, so the C in FCR cross-links DNA, and the purine analog replaces a new analog into the DNA. So it works to kill cells by changing the fundamental nature of the DNA. And that's why in some of the data Nick presented, which showed this higher rate, particularly of hematological cancers. And so the fear about giving chemotherapy to younger people is that you've got 30, 40 years mapped ahead of them, and what are you doing in terms of genomic toxicity? And that is possibly to all stem cells, not just hematopoietic. And we've got some data we're submitting from the Hodgkin's world, sort of mapping out stem cell damage from particular chemotherapy drugs. So my sort of slightly provocative comment was, well, when targeted therapies don't work, maybe therapies that are a blanket bomb. It's like your drone targeted thing doesn't work, so send the cluster bombs.
I understand some of that, but shouldn't it also be part of the discussion with the patient community? It's not that was my point, really. Not that I'm a huge advocate of it, but just.
So I definitely agree that also there are people who had FCR 20 years ago and have never returned to CLL, and these people think it's crazy having this discussion. But I think Nick was drawing out that comparison in CLL 13, where the venetoclax obinutuzumab in young people, which, fair play to NICE and NHS England, they let us bring that in to young people in the NHS before we had that data. And again, CLL Support Association, CLL Forum, we lobbied hard for that drug on sort of reverse age discrimination. And now out comes the German data. And look at those mutated IGHVs. So the people who defended FCR are still, they have to look at this data in young people and see those venetoclax and obinutuzumab with such a low relapse rate. Those guys, there must be a decent chance that 20, 30 years from now, quite a chunk of them have never relapsed. So I think the power of our newer therapies, venetoclax based, really are pushing chemo into distance. But for those unlucky people that are relapsing through all our drugs, of course, when we've got a patient who's had ACALA, they've had venetoclax, they've had pirtobrutinib, and they come into our clinic relapsing, we are going to be reaching for bendamustine rituximab or FCR, because we would. It's, you're not going to let somebody die who's fit enough to have chemo, as a final comment. But my comment is really that could be when we've all retired. So we've kind of retired with our chemotherapy experience, and then new people will discover it again.
And can I just say discussing with a to back to your point, Lilia. So discussing with a patient that's going to go into potentially go into chemotherapy with a new diagnosed or recently diagnosed CLL, who then you're thinking about side effects, etc., chemotherapy, and then having a big discussion and sort of an informed discussion about the risk of secondary cancers is really difficult. I personally find it very difficult, not because you can't have it, is because it's either underplayed or overplayed, and it's really difficult to keep it fairly balanced, and it's difficult to to get the right tone with patients into what the actual risk of secondary malignancies is, and the secondary malignancies can be as easy as a basal cell carcinoma and as tragic as a secondary AML, which is completely refractory to therapy. And once you've seen that, and then from our perspective, doctor perspective, once you've seen that once, you're quite scarred in many ways, because you then
it's
realize,
an experience of one, but
yeah.
it's a very strong experience of one.
Mm.
I mean, basically, that anecdote. Yes, I mean, you're absolutely right. Once you go through this, and I had a unfortunate experience going through somebody, with having those problems. Yeah, I mean, it's just truly experience how you think about those things. I realize we passed time. I think it's very important we answer those questions, but I just want to remind you all, whoever joined us today, so thank you. And if you could do the exit polls, because it really helps us to organize another course, and which could be very useful for you, and how we can improve it. So very quick question, maybe Helen, if you've got somebody stable on ibrutinib, no toxicity, and you've got obviously Acala and Zanu, they've got ongoing CR. Rock that boat? Change it? No, change it.
I probably wouldn't rock the boat. I mean, officially, you're not allowed to rock the boat, are you? Because they have to have a reason to stop there. You'd have to make up some toxicity, because you can only change them if they've got some toxicity, and that's why you're stopping the ibrutinib and moving on to something else. So you'd have to fudge it on the piece of paper and make up some toxicity to change them. Personally, I wouldn't, unless, unless the patient is expressing to me that they're worried about toxicity, or they're concerned about being on the ibrutinib. I wouldn't, if they've been completely toxicity free and they're getting on with it fine. Yeah.
And Nick, BTKI with significant cardiac disease, safe to use? I mean, obviously there is the AZ is about to start the study about sort of choosing specifically patients with cardiac, but currently, what would you do?
Well, the first thing to say about cardiac toxicity is really important to really know exactly what cardiac toxicity is. It's different if a patient has hypertension, whether they have ischemic heart disease, or whether they have heart failure. For me personally, hypertension is manageable and should be managed appropriately. And if you have controlled hypertension, you are probably okay from that point of view. And there's data that shows that actually the poorly controlled hypertension that has been driven by the BTK is actually what is driving the high risk of cardiovascular problems.
And if I could just quickly jump, I think it's so important to empower our patients and just give, I think that's what pandemic did, one of the good things, because they don't come to clinic anymore. And I think it's important to tell them, get that sphygmanometer, measure that blood pressure, and give them, give them the choice, and they need to sort of, it's being accountable for your health. It's not all down to us, and I think it's so important. Sorry to jump in.
Yeah. Second one is heart failure. To me, heart failure is a no-no, because then you're very likely to damage that person's life quality with risk of sort of heart failure exacerbations, etc. And then ischemic heart disease depends on a big concern, because these people have fertile ground for arrhythmias, and then you will be probably this is the group of patients that would have the highest risk theoretically of sort of ventricular arrhythmias, etc. And then AF, again, manageable. I think these ibrutinib has shown that probably has the least amount of AF compared to the others too, but the numbers are very small, so it's very difficult to draw these conclusions from cross-trial comparison with an event that has an incidence below 10%. So again, there's what numbers show, but you cannot be too categorical about it. So those would be my suggestions.
And maybe parting question to George, just very quickly, were you convinced with that zanubrutinib is the treatment of choice for P53 deleted patients and mutated?
So I think you've just got to be quite careful. These trials are different eras, slightly different things. If you want to cross-compare trials, you have to remember that the headline PFS figures are pretty equal between them. I think choose your BTK based on what you feel about. Nick didn't get himself drawn into them. There's similar efficacy, there's similar toxicity. As I always say, Acala, we're so familiar with it. It's BeiGene's job is to try and make us feel as familiar and comfortable as zanubrutinib. I think there are very few instances where you're right or wrong. In the private clinic, Nick hinted at this. I think this is a real shame that we can't get acala plus obinutuzumab in the NHS. I think that is influencing private prescribing.
Although I've got to say, I've had a chat with AZ and they're promising, but whether it's happened, that they're going to take AO to NICE. So watch this space.
Amazing.
Fingers
well done.
crossed, fingers crossed. So on that note, thank you to my co-chair, George. Thank you to speakers, Helen and Nick. And thank you to our fantastic patient representative, Lilia and John. And so thank you all. Have a good night and I'll see you next week.